Good evening, ladies and gentlemen. It is with great pleasure that I welcome you to this public lecture. This event is organized by the University of the West Indies Open Campus, St. Kitts and Nevis site. The current UWI strategic plan outlines the three strategic goals, namely access, alignment, and agility. Under alignment, one of the objectives for the St. Kitts and Nevis site is to increase discussion on matters of national importance. It is against this background that I'm excited to collaborate with Dr. William Stones and Dr. Linda Carty to discuss a topic that is timely towards universal health coverage, a medical perspective. A warm welcome to officials from the government of St. Kitts and Nevis, including representatives from the Ministry of Human Settlements, National Insurance et al., medical officers, university colleagues, and special invited guests. A special welcome to persons who are joining us from outside of the Federation. I gather that persons are joining from the United States, Canada, and the United Kingdom. Special welcome to our guest speaker, Dr. William Stones, specialist of obstetrics and gynecology at Eureka Health Services in Nevis and professor at the Malawi College of Medicine. It is indeed an honor to welcome Dr. Stones, and I look forward to his presentation. My colleague, Mrs. Isabel Byron, site coordinator for Nevis, will tell us a little bit more about Dr. Stones in a few minutes. Special welcome to Dr. Linda Carty, our moderator for this evening. Dr. Carty hails from Nevis. She's a Black feminist scholar activist, an educator in the African American Studies Department at Syracuse University. Linda's activist research, scholarship, and teaching spans Black women's health, labor struggles, migration, and sexuality in Canada, the Caribbean, and the United States. She has published widely in these areas. Her most recent book, published in 2018, is a co-edited collection entitled Feminist Freedom Warriors, Genealogies, Justice, Politics, and Hope. She has worked with UNAIDS Caribbean Women's Health Association, Migration Services in New York City. She's a founding member of the Democratizing Knowledge Collection and Project at Syracuse University. Dr. Carty is also the founder and director of Gender Central, a Caribbean NGO that puts improving the lives of women at its center. Before I hand over to Dr. Carty, I encourage everyone joining us via Facebook and YouTube to post your questions and comments in the chat so that Dr. Stones and Dr. Carty can address them. I look forward to a very interactive discussion. Welcome again to everyone. I now hand over to Dr. Carty.
Thank you, Dr. Phillips. I am pleased to be here and happy to be introducing Dr. Stones and to be moderating this session this evening. And I am also looking forward to a very exciting discussion. William Stones graduated in medicine in London and then undertook a research doctorate and specialist training in obstetrics and gynecology. He worked as a UK National Health Service consultant, medical school educator, and clinical researcher at the Southampton before taking up the role of department chair and professor at the Aga Khan University in Kenya in 2007. He moved to Malawi in 2014 to develop a collaboration between the University of St. Andrews, Scotland, and the University of Malawi, focusing on global health and implementation science. Since relocating to the family home in Nevis in late 2019, he maintains an active research and teaching program with Malawi College of Medicine via online channels and has a specialist obstetrics and gynecology practice in Charlestown here in Nevis. Welcome, Dr. Stones, and we look forward to your lecture.
Thank you very much, Dr. Carty, and also thank you to our chair for this evening for setting the scene for the and also that those priorities of University of West Indies, which I was interested to hear about. And let's hope we can tune in and align with some of those. So welcome to anyone tuning in, and a very welcome, pleasant good evening from the island of Nevis. We've had a lot of thunder and some heavy rain this afternoon and a little bit of lightning, but things seem to be calming down. So I'm hoping that our session won't be interrupted by the forces of nature, but we never know. So what I'm going to do this evening is I'm going to give a talk for about half an hour with some slides, and I'm going to start my slide set in a moment, and then Dr. Carty will pick things up a bit, and we can see where we can go with some discussion, and I'm really looking forward to this. So I hope my slide set is now on the screen, and I guess it's traditional to start with a disclaimer, and this is, I'm not an actuarial scientist, so I'm not going to be saying anything at all about healthcare financing, which is definitely beyond my scope, and that's really one of the points of the choice of title, that this is a medical perspective on universal health coverage. As you will see, we are going to delve into some of the technicalities of health systems and quality of care. But the financial dimension, which is of course absolutely critical, and I don't want to minimize the importance of that, but it's somewhat beyond my sphere of expertise, so I'm not going to be venturing into that territory. So my affiliations were mentioned earlier on by Dr. Carty. I'm currently associated with, still since moving to Nevis, and really thanks to the boom in online communication that has even reached as far as the Southern African country of Malawi. I still have an active research and teaching program with colleagues at the Centre for Reproductive Health in Blantyre, which is the home of the College of Medicine, now recently renamed Kamuzu University of Health Sciences, previously University of Malawi. Before, I've also had affiliations with University of St Andrews in Scotland, as was mentioned, as the chair of global health implementation, which really reflects my interest in health systems and implementation issues. And then before that, my African experience started in Kenya with Aga Khan University. I don't have any interest to declare, no commercial potential conflicts or other kinds of conflict of interest, but of course I am interested in the topic as both as a practitioner, but also of course as a potential patient, and as someone who is now reliant on the health system in the Federation of St Kitts and Nevis. I'm not divorced from that issue in a personal way. So I mentioned the lecture is going to cover some definitions and key concepts underpinning universal health coverage. And I'm going to link it to the Sustainable Development Goals, which I think are a very important global platform for development in national development and regional development, and indeed global development, in which the world has been able to come together with an integrated set of priorities for development activities. So we want to see how universal health coverage fits into that agenda, that global agenda. I'm going to talk a little bit about the World Health Organization building blocks for health systems, which again, I think is a very useful framework. And then on to talking about quality, access, quality, and protection. And then perhaps the first half is can get a bit technical, and I'll be showing some technical slides, which might be of interest to some. For others, they may not be of interest, and my apologies if I skate over those. But the second half, we'll be focusing a little bit more on the practicalities of, do we think that the currently discussed model, which is universal health insurance, at least in the Federation of St. Kitts and Nevis, that's the language that's been used recently in government announcements, is that the model which will deliver universal health coverage? So with some subheadings there around access, quality, and protection. And I'm going to conclude with really a bit of advocacy for what it seems to me, again, coming from a medical perspective, looks like what might be a sensible way forward, which is the concept of care pathways. And we'll be talking about that towards the end. So first of all, a bit of definition of terms, and this is from the World Health Organization site, and the definition is access to all people to the health services they need, and that includes prevention, promotion, treatment, rehabilitation, and palliative care without the risk of financial hardship when paying for them. And that last part is naturally, I think, very important to all of us, that we want to avoid the risk of catastrophic expenditure suddenly being required in an emergency, or indeed hardship just to go and visit the doctor or visit a clinic. And then the first word, access, is an absolutely critical issue that however we might manage to come up with that in terms of a financial model, the key question is, are we delivering access? So I mentioned the Sustainable Development Goals, this set of global goals. There are 17 of them currently in operation. And the Universal Health Coverage Agenda has made its way into the Sustainable Development Goal for Health, which is SDG, as people say in the jargon. SDG 3 is the health-related Sustainable Development Goal. And within each goal of the 17, there are targets. And within Sustainable Goal number 3 for health, there is a target which happens to be numbered 3.8, which is to achieve universal health coverage, including financial risk protection, access to quality essential healthcare services, access to safe, effective, quality and affordable essential medicines and vaccines for all. And that's quite an ambitious agenda, but there it is as a target. And this is a target for the world, for all countries, all regions, under the banner of the Sustainable Development Goals. So what is the current state of play? And one convenient way of classifying countries is in terms of, as far as their healthcare is concerned, is to divide based on, is the service free at the point of use? Of course, nothing is free in life, and health services are very definitely not free. But the question is, do you have to pay for things at the time of need? If you suddenly require care, do you have to immediately get your wallet out? And it may be free, or it may free at the point of use, but it may or may not then be universal. And this is just a global map with green representing colours which are have some form of universal health coverage, which is free at the point of use. And then the other colours reflecting other shades of availability. So for example, we see in the US, we have not free, but universal. So there's widespread availability of health services, but very often there is payment at the point of use. And then we have countries such as many of them in Africa, where services are nominally free, but the coverage of those services is very patchy. And that would certainly be the scenario in a country like Malawi, which has been an area where I've had experience. So this would be our kind of global overview. And then what about the Caribbean, and in particular, what about small island developing states? And this is, again, a category of nations that has received quite a bit of attention within the UN system. And there is a whole grouping of activities, development activities related to small island developing states, of which, of course, many of the Caribbean nations are part. And the development agenda for small island developing states within the UN system has taken due note of the Sustainable Development Goals and pathways to reaching the Sustainable Development Goals and how those can be achieved in the context of small island developing states. And this is just an example showing one of the tools that's been used to try and assess where particular small island developing states might be at in their progress. And there's this multi-dimensional vulnerability index. Now, it's interesting to note that the health goal, Sustainable Development Goal, actually doesn't feature in this particular multi-dimensional vulnerability index. Gender equality, which is Sustainable Development Goal number 5, does, but number 3, the goal for health, is actually not part of the agenda in this particular part of the UN system, focusing on focusing on small island developing states. And I have to say, I think that is unfortunate and is definitely a gap that perhaps the policymakers might want to have a think about. We do, however, have various indexes to measure universal health coverage. Beyond that sort of traffic light colour map that I showed, there are more nuanced ways of measuring the existing level of coverage by universal health care in countries. And in particular, the WHO and the UN system uses an indicator based on 14 components, which is selected to reflect Sustainable Development Goal 3.8. And they mainly focus on reproductive, maternal, newborn and child health, infectious diseases, non-communicable diseases, and there are a couple of indicators for service capacity and access, reflecting, if you like, the functionality of the health system as a whole. So just out of interest, it's interesting to just look at what that particular index tells us. And these are data from 2017, which is the latest available indexes that are available. And you can see at a glance, essentially, this is a 100-point scale with 100 being very good and 0 being not so good. And if we look at in the top left-hand corner, we've got some African countries, and you can see that this particular index is hovering for many countries around 39, 41, etc. With in the African continent, South Africa featuring, or sub-Saharan Africa, South Africa featuring most favorably there at 69. And then at the bottom, in the bottom left-hand corner, we've got some European countries. We've got Ireland at 76, France at 78, Austria at 79, and the UK at 87. So if we move across to the right-hand side, we've now got the region. So we have, again, this is in order of increasing order of index score. So we can see that Haiti is down at 49, ranging through Belize, Jamaica, etc., as we come up through Trinidad, Bahamas at 75, Cuba at 83, which I think reflects the very major investment that Cuba has made over a long time, especially in primary health services, reflecting very high rates of coverage. And then we have the US and Canada there. So I don't want to over-labor this particular index because it's just an index. It's a number based on looking at different indicators and doesn't necessarily tell you what life is really like for people using health services. So what's been happening in the Federation of St. Kitts and Nevis with regard to the universal health coverage agenda? And this is just I'm not going to go through these documents in detail. There's a lot of work has been done by the Ministry of Health in Federation of St. Kitts and Nevis, including a green paper in October 2018 with a consultation And it's a major part of the agenda for country cooperation between the Federation of St. Kitts and the World Health Organization. And then most recently, I think perhaps this is what piqued my interest in the topic, was there's actually been a little shift in language in that the government is now talking about universal health insurance. And that really sort of piqued my interest. And I don't know, I'm not part of in any way of the policy making process, but the fact that we've seen that little shift in emphasis from universal health coverage through to universal health insurance, I think is something that will require or merits discussion. And we can say that, of course, insurance mechanisms are a way to achieve universal health coverage, but they are not the same as universal health coverage. And I think it's important that we bear that in mind. So naturally, the world has been convulsed in the last 18 months or so with the COVID-19 pandemic and the health system response to that. And I think one thing that commentators have very loudly commented on is how the countries that might have been expected to do very well, and especially perhaps some of those countries that had some of those high scores on those indexes, those clever indexes with indicators, actually didn't do very well when it came to the COVID-19 response. And well, I'm sitting on the island of Nevis, which is one of the very, very privileged parts of the world in terms of the response to COVID-19, which has been fantastically successful in preventing spread of the virus to the Federation. With a little outbreak, there's an outbreak going on at the moment, but that's, well, in a way, I guess, inevitable. But by global standards, really, very, very remarkable achievement. But I think it's true to say that the wider health agenda for countries has been somewhat on the back burner in terms of everybody's thinking. Really, people have just been, I think, policymakers, governments, ministries, other sectors have just been trying to figure out how the hell to respond to this pandemic. And the longer term developmental health system agenda perhaps has faded a little bit. But at the same time, countries are now starting to think about what happens after COVID. And I don't think there is going to be an after COVID. And again, that's of course part of the current debate. But as we learn to live with COVID, the old health system challenges and health system issues are going to come back and still require attention. So I think with that in mind, the UN convened a gathering in, I think it was December 2020, towards the end of last year, to try and refocus attention onto universal health coverage. And there's quite a nice YouTube, I recommend a YouTube clip, which just with the link is there. And really, I think trying to revive the interest of countries in the future of universal health coverage, and perhaps also to think how it could be an important part of the rebuilding of health systems, which is likely to follow in the coming years. So one of the things that I believe has been happening in Federation of St. Kitts and Nevis, and this is mentioned in the Green Paper of 2018, is a search for suitable prototypes. Now, I've mentioned the issue or the context of small island developing states, but here we are in St. Kitts and Nevis, which is a very small developing island state. And small means in the UN system means, just, 1 million or 2 population. We don't have, as far as I know, I'm not sure that there is a specific United Nations category for very, very small island states such as our own. And this actually is a problem, because if you're looking for a suitable health system model, where do you look? And very appropriately, the government was looking at other very small islands, and with similarly small populations, and what models could be drawn upon. So the prototypes that have been mentioned are those of the BVI, British Virgin Islands, and the Turks and Caicos. And they each have a slightly different model, And again, I'm not going to go into this. It's not I don't have direct knowledge of these two systems, so it's not appropriate for me to dwell on that. There may be others in this discussion who do know more about how these things have worked out. But these are essentially insurance-based models administered I believe in somewhat different ways, but they do follow a pattern similar to what we might expect from a typical commercial health insurance. In other words, there are fee-for-services specified for practitioners undertaking consultations or procedures, or there's a list of eligible tests that can be ordered under the scheme, and then perhaps something again that we might look at in a bit more detail is the question of exclusions. And indeed, as with typical commercial insurance policies for health coverage, there are exclusions of various kinds, and so it basically follows that format, which is really very similar to a commercial insurance product, but this is a state-mandated provision. And as if I've understood correctly, the entitlement is typically via employment. So let's step back a bit now to look a bit more at some of the concepts that we want to try and bring to bear to our thinking about universal health coverage. So this is a slide that gets heavily used, at least by those of us who teach health systems in lectures. It often pops up. It's from a World Health Organization document about the health system framework. And it's a very useful slide. And I think it really summarizes the health system on a single slide very effectively. So on the left-hand side, we've got this health system building blocks. These are the components that are required to make a health system work: service delivery, health workforce, that means doctors and nurses and allied health professionals, laboratory scientists, etc., physiotherapists, information, access to information about health conditions, disease conditions, medical products, vaccines and technologies, financing, which, as I said, is not my field, but of course it's absolutely critical. And then again at the bottom, leadership and governance, which I think, again, we can see are absolutely critical to a successful health system. And then on the right-hand side, we've got, well, what is it all for? What are we actually aiming for? Well, we're aiming for improved health, and both in terms of the level of health that we can achieve through the avoidance of disease, prevention of disease, recovery from illness, rehabilitation, and even at the end of life, a good quality of end-of-life care. So all those things is what we're aiming for, but we're aiming for them with equity. So in other words, having great disparities within a society in access to improved health is very undesirable. Responsiveness is an outcome in a well-functioning health system that we should appreciate and aim for. We want a system that does respond when we need it and is alert to the needs of the community and of individual patients. That there is this strong component of social and financial risk protection. We don't want, or a society does not want, its citizens to be bankrupted as a result of getting sick. And unfortunately, in many settings, that is indeed a major risk. And then, well, there's always a need for improved efficiency. And in any country, the health system consumes a huge amount of resources, and whatever the source of those resources, whether these are out-of-pocket payments, whether these are third-party payments from insurance providers, whether this is direct taxation being used to finance the health system, it is huge typically as a percentage of gross national income, and therefore there's a responsibility on all of us to make sure that those resources are being used efficiently. So we've got those on the right-hand side as the goals, overall goals for the health system. But it's the bit in the middle which to me is really the most interesting. And the red rectangle is not from the original WHO document. I've added that red rectangle because I think it's very important. So these aspects of access, coverage, quality and safety, to me, this is really where the individual physician or medical practitioner or healthcare professional, what that is really their role within the health system to ensure and to contribute to those components. And if you like, this is what we are looking to achieve. So quality is a very important one. And again, I think I'm going to scoot through this fairly rapidly. But again, there are well-established frameworks for considering quality in healthcare. And again, these are some of the useful headings: outcomes, process, structure, outcome, structure, and process, which I'm not going to go into in detail, but these are things that we've devoted a lot of energy to. And these do reflect in some national policies and statements of how to implement an effective health system. This happens to be one from the British National Health Service, NHS England, which is, I think, a very nice conceptualization of quality in terms of these 5 domains. And it's got the, if you like, the health outcomes at the top: preventing people from dying prematurely, enhancing the quality of life for people with long-term conditions, helping people to recover from episodes of ill health or following injury, this idea of restoration. And then we've got domain 4, a positive experience of care. And this is something that I'm going to keep emphasizing in the remainder of this presentation. And then, of course, the final point of caring for people, treating and caring for people in a safe environment. And well, how important has that been in the last 18 months in this in the COVID era, protecting the health workforce? So there are other ways of conceptualizing quality in healthcare. This is one, the Halton quality framework, which is taken up by WHO. And again, this particular one was developed for maternity services. And I'm showing it really just because it emphasizes the interplay between the provision of care, in other words, the technical content of what the doctor or the nurse might do for you, and on the other hand, the experience of care, effective communication, respect and dignity, and emotional support. So those aspects feature very prominently in that particular framework. And it comes down to the bottom in terms of outcomes reflected as people-centered outcomes. Not just technically favorable outcomes, but also people-centered outcomes when we're considering health outcomes as a whole. I think I'll scoot past continuum of care because that's, I see time is pressing. We do have some problems with data. And again, I'm coming now back to the particular context of small island or very small island states. And if we happen to browse the World Health Organization or interagency UN databases for metrics, we actually find when we look at states with populations below 1 million, that actually they're not there. States below 100,000. The data are not there. So, for example, we can look up quite a bit for Barbados and a lot for Jamaica, etc. But when it comes down to populations below 100,000, there's just a dash. And that's perhaps for a good reason, in that when we have a very low population, the meaning of health outcome data can be difficult to interpret. And I've shown here an example to do with newborn mortality. So this is something that actually is available in the statistical archives, which shows the death. This is deaths of babies born that are born alive, but sadly succumb and die in the first month of life. And as you can see, over the years, since 1980 through to, I think, the last available data in 2019, you can see there's been a steady decline. And the red line is the point estimate for each year for that particular variable. But the blue line and the greeny line above represent the error margin for those estimates. And they're very wide. So you can see that to make a very firm statement about a change in a death rate, a neonatal mortality rate from a year to year, or even from 2 or 3 years, is quite difficult because it could just be within that bound of that error margin. So that gives us a practical problem of knowing how good our health system is in terms of its health outcomes when we want to rely on these kind of statistics. I'll show another example briefly, which would be maternal mortality. Now, the available data only go up to 2010 in the Federation of St. Kitts and Nevis. And typically, in periods of time that are studied, there are typically 1 or 0 deaths each year from complications of childbirth. And of course, that's excellent. But again, it really reflects the small numbers. So typically in the period under review there's probably been around 690 births in the Federation of St. Kitts and Nevis. So imagine what would happen if, if there were no deaths. We could say, well, maternal mortality in our federation is better than Western Europe, it's 0. But if we happen to have a single case in a particular year, that would put the rate, which is usually expressed per 100,000 live births, on a par with Pakistan, or with 2 deaths, it would put us on a par with Mozambique, or with 3 deaths in a year, it would put us on a par with Haiti. So it's really very difficult to use those kind of statistics to really say anything useful, because things can happen from one year to the next, and it's very hard to interpret that based on these ratios, which require very large numbers. So in our setting of very small healthcare populations seeking and using healthcare, it's probably better to use other indicators. And there are lots of other ones that we could go for to assess quality, and rates of certain complications are perhaps things that we can use. So what conditions do we need to think about for access for universal health coverage? Well, persons need to be actively engaged in the health system, even if they're not seeking services, even if they're not ill. So young, fit, healthy people need to have a relationship with the health system, even though they don't need it at the moment, or they may not need it at the moment. Of course, some young people do get sick, but practical steps that one might think of would be things like health centre registration, so that we have a database of everybody who is potentially in need of services. And then information provision. And I'm aware even over the small island states in the Caribbean, their demographics are changing. And especially we have a more mixed society. In St. Kitts and Nevis, there's a growth of a Spanish-speaking community who may or may not be able to access information about the health system very easily. And then there's a question of convenience, things like opening hours, given that in general, we often find the public health system functioning during, in inverted commas, normal working hours. And of course, most people are working in normal working hours, or going to school, or otherwise occupied. On the positive side, we do have our network of health centres as opposed to hospitals. And I know there's been discussion of ideas like polyclinics and extending the range of services that might be available through that health system network, so that it's not that everybody has to travel into town to the main hospital. So there are some other angles that need to be thought about. Confidentiality and privacy is such a huge issue, and in a way, the smaller our island, the bigger an issue it is. And living in Nevis, what are we, 11,000? Everybody knows everybody, and we don't want everybody to know our business, especially not when it might come to our sensitive matters of health. We do have the 2018 data protection law, but my understanding is it hasn't yet been operationalized, for example, in a manner that might allow persons to seek redress for a suspected breach of data protection. There are some processes for anonymized consulting or testing for sensitive conditions. That's something that is in place. Consideration of persons with disabilities, responsiveness. Do we have liaison forums with patients or client users of the services? And then as an obstetrician gynecologist, one of the things that I've been very aware of since taking up practice here is the colonial legacy restrictions, legal restrictions that remain in place in our federation, and indeed in a number of other Caribbean states who are still operating with some colonial legacy laws. And in particular, I think the one that bothers practitioners quite a lot is the one that restricts access to reproductive health services for adolescents. So the age of consent for sex is 16, but the age of consent to seek medical services, for example, if you want contraception, is 18. And clearly that doesn't make any sense and is something that needs to be addressed. So let's think of some examples with regard to screening. We've got, in the context of cervical cancer, how does the current context play through into what really happens when it comes to screening? Well, we know that cervical screening, pap smears to prevent cervical cancer is a very useful and effective strategy. But the practical problem is that a lot of women who come for screening, and there are many women who do attend absolutely very regularly to have their screening tests, they unfortunately are not the ones who are really at risk. The people who are really at risk are those who have never attended for whatever reason. They may have a lack of information, they may have some anxiety about it, and these are the people who are the ones who sadly are likely to develop problems and may have early cancers which don't get detected. So that focus on the population, the eligible population, is something that is really, in my humble opinion, would be a gap. Similarly, for breast cancer, there's a lot of emphasis on breast screening and breast cancer awareness, certainly in our setup in the Federation. But we don't yet have a systematic screening program, including mammography, and again, based on a population register with things like call and recall, to ensure that those who are most at risk do actually avail of the screening technology which might be available. And there are certain conditions which now we can screen for, which we don't yet have an infrastructure for, especially colorectal cancer and prostate cancer. And again, these tests can be arranged by your doctor, but that's not the same as a kind of public health strategy involving the at-risk population and making sure that all the persons who may be at risk do avail themselves of the opportunity for screening and referral. So then what about, that was a bit about screening tests. What about quality when it comes to complex procedures or high-end specialist procedures? And one of the big problems that I think we need to grapple with is the issue of quality in the context of low volume. And I've just suggested here an example of cardiac care. There are patients who have a heart attack who need rapid cardiac catheterization to unblock their coronary arteries so that the heart muscle does not get damaged. And this is something that we would all like to have access to in a timely way. And when I say timely way, I mean an hour or two from the initial episode. But there is a practical difficulty that to do these procedures is a very high-end, technically challenging procedure, which is done by a specialist interventional cardiologist. Now, if one is planning an interventional cardiology service, one of the critical issues is the numbers. And how many cases are going to come through a system, and are the numbers going to be sufficient to allow our interventional cardiologists to maintain their skills? There are certain things in medicine which are, you don't forget, like riding a bicycle, but there are other specialist procedures and highly technical, highly complex procedures where you have to be doing it every week or every day in order to maintain your level of skill, and cardiac catheterization would be a good example of that. There's also evidence from many other health conditions involving surgery that, in general, the best results tend to come from surgeons who have a high volume of specialist or subspeciality practice in that particular condition. So in other words, somebody who's doing it all the time is the person that you want to have operating on you, especially for complex care. So this is quite difficult given the sheer population statistics that we can't necessarily deliver a lot of the full range of these specialist services, which do require that level of consistent activity for practitioners to maintain their skills. There are, on the other hand, opportunities in certain other specialist areas, and imaging is probably a very good example. Persons can have a scan, they can have a CT scan or an MRI scan, and the interpretation can be done remotely by a radiologist who may not be in the country, or they may not be in the same island, but they can do that. And again, this particular condition that perhaps we really need this sort of capacity for is when it comes to stroke, where we need to very rapidly determine the nature of the cause of the stroke to determine the treatment. And again, that's something that really we want to happen urgently. I'm going to scoot over cancer care a little bit, because, and of course, that's another very critical issue for universal health coverage. A lot can be done locally. Screening, biopsies, standard surgery, chemotherapy can indeed be done in a small island state such as St. Kitts and Nevis. But certain other things are always going to require referral abroad to centres with high volume, especially when it comes to complex surgery and radiotherapy. And there are indeed regional initiatives around this, such as the harmonised guidelines for the Caribbean on treatment pathways, which give quite a good guide and have been developed in a consensus kind of way. But the approach that's really needed is the ability to match our patients with the right pathway of care. And in the jargon, we sometimes talk about tumour boards, where a group of specialists would come together and agree the recommendations for a particular patient based on that particular patient's cancer and the potential for treatment. So to achieve access and quality for complex care, we have to be able to address these issues. And the referral destination has to be accessible, and it has to be affordable. And ideally, we want long-term linkages with no physician would like to dispatch their patient to an unknown destination, to an unknown practitioner with whom they don't have any professional relationship. And similarly, when the patient comes back, they would expect to be involved with the ongoing care of that individual. The care pathway needs to be known and planned. And then again, that issue of volume, which I've already mentioned. And it would seem to me that we perhaps, up to now, I know there are some extensive linkages with individual practitioners and colleagues that they have worked with over the years. But it's possible that we're maybe underusing the regional, and I'm especially talking about the Eastern Caribbean, the regional university hospitals. But there is, of course, the Caribbean Programme for Cooperation in Health, and we're in this current phase of cooperation, 2016 to 2025, which comes up with this is premised around this very interesting concept of regional public goods, and this is something that I think we should hold in our minds. The idea of a regional public good when it comes to health systems, I think, is a really useful concept. So, of course, we have Barbados within flying distance. We have Guadeloupe, and I know we have patients going down to Martinique, and of course, some patients would opt for treatment in Cuba. So, what should be done? What can be done with regard to national and regional public good-oriented measures? Well, a health sector strategic plan would be a good idea to define the scope of national implementation of universal health coverage, and particularly highlighting limitations in a transparent way to enable people to plan. The scope to coordinate healthcare professional training and deployment with career progression. We do have a number of young doctors coming back following their medical training or specialist training, and I think it's unfair just to let them, leave them alone and say, okay, get on with it, do what you want to do. Ideally, we want to have a career pathway for practitioners, because these are people that a lot of resource has been invested in, and they're going to be with us for many years, providing services. And I think building up those university hospital linkages are especially important, as is the role of healthcare professional associations. Because of the small numbers of specialists, the functionality of speciality associations in the small context is perhaps a bit limited. I've mentioned remuneration here, and then professional indemnity cover is an important point for practitioners. Again, with small clinical volumes, actually getting good professional indemnity insurance is not easy, and it's actually a barrier to the growth of the medical system. I touched on some of the perhaps hangover legacy aspects from the colonial era around the legal context, and I think when it comes to health system governance, it's not something, in my view, that ideally lends itself to the traditional civil service model with well, all those features. We really need something which is more like a kind of a board or a trust kind of model in order to really get that element of responsiveness. And there's discussion, I know, in development circles about a mission-focused approach to investment, focusing on outcomes, integration of public and private provision, and a balance of prevention and curative services. We also have to manage the conflicts of interest. So I'm nearing my conclusion, and in a way the most important last couple of slides, which is, can universal health insurance deliver universal health coverage? And I think there are questions rather than answers here. Perhaps we'll get some answers in the discussion. One of the problems with insurance as a concept is that it tends to be feasible for, in the context of health insurance, feasible for employed people who might be in a position to pay premiums, and it's also quite good for people who are not sick. But the less employed and the sicker you are, the more challenging it gets, because you then start to run into issues of exceeding your cover limits, or running into problems with exclusions, which may not fully address the definition that we gave at the beginning about universal health coverage. I'd also just touch on the diverse needs in our increasingly diverse population. We have a lot of people who were born in Nevis and have spent maybe some of their professional lives abroad and are now back. So they may have access to some services from another country. There are quite a few people in St. Kitts and Nevis who are able to access services, for example, in the USA as a result of having spent time there. There are retirees, and we have people with long-term disabilities or chronic conditions who really would be uninsurable in a conventional model. We have to think of the new normal with COVID. We have to consider the big explosion of online activity that's gone on. Funnily enough, some of the third-party payers currently actually don't reimburse for online consultations, and that's kind of a bit of an oddity in this day and age. And then I'm not going to go through all these things in detail, as I think we're out of time, but as we rebuild, as the world rebuilds, some of these elements will come through. So I mentioned that the programmatic approach of care pathways is, to me, something that I would like to bring forward and put forward as a potential way forward. And kind of covering time-sensitive conditions, some of which I've mentioned, chronic conditions, and then conditions of public health importance, including sexual and reproductive health, and of course infectious diseases, where there has to be that public health focus. And the experience of care, as I have said, is as important. It's not more important, but it's as important as the technical content of care. As we were planning this talk, I was reminded that it's important to actually also remember what goes on in the community in our small island. We have herbalists, we have people who are very interested in wellness and natural healthcare. And these parts of society need to be incorporated into the health system through the universal health coverage model. So in concluding, I would say we have these low-hanging fruits, registration, and we have time to get on with developing care pathways. We don't have to finalize the model for universal health coverage, these are the things that we could be getting on with in the meantime, because they're going to be needed anyway in whatever model of health coverage is finally agreed upon. So perhaps this is our vision to finish: healthy, engaged citizens and residents, accredited health facilities with a good skill mix among the healthcare professionals, expanding healthcare infrastructure, collaborative networks for referral, a pipeline of young healthcare professionals settling in the Federation to build their careers. And perhaps we all depend on investment from external investment, investors attracted by excellent healthcare. And I'll finish there. And hand back to Dr. Carty.
Thank you, Dr. Stones. That was a really comprehensive lecture with many discussion points and some parts controversial, or can become controversial. I find it rather intriguing. I would like to, I'm not going to recap what you said, but I think you made some significant points that are worth mentioning again. And for me, one of the crucial ones is, can universal health coverage or universal health care really lead to, care that is easily accessible, care that is affordable, care that is of high quality, and how will all those be managed? I like the fact that you underscored a few times that this is toward universal health coverage, a medical perspective, not a financial one, not a political one, but a medical one. And that's important for us to take our discussion from that angle. I would say, let's see if we have questions as yet. Questions will be coming in, and I don't want to take up time with my recapping of what you said, but I would like to take the prerogative as the moderator to ask you a question. Do you think that the universal health coverage can lead to quality healthcare in what I call tiny island states? We know that the UN doesn't have a designation for small island nation states, and you rightly pointed out that populations of less than 100,000, then data doesn't show up. That's one aspect. I want to point to another though, and that is that oftentimes, global South countries, large ones and small ones, and particularly tiny ones, don't have the resources to do the data collection. So oftentimes when we're looking at statistics, we have to keep in mind that the dashes may represent maybe data wasn't collected, or maybe they didn't have the resources to collect data, or they're just not there. Or when they're there, we have to question if they're misrepresented. I have experienced that with some countries, that you use the data and then you find out that it was inaccurate. So considering all those obstacles that are hard to manage and outside of the control of, the nation state itself and tiny countries like ours, do you think that universal health coverage can be taken care of through national insurance?
Thanks. That's I can't really answer the question about can it be done through insurance. I think I personally am not sure whether that's the best mechanism. But can it be done? I think we actually have tremendous potential, and even the health center infrastructure is tremendous. I mean, it's from what I've seen I'm obviously not working in the government service, but I have visited health centres. And it's interesting to see that, I mean, the nurse in the health centre, she does know the community. She knows who's got the issues, who's got the problems. And I think strengthening that component of the health system can yield tremendous results. And again, with regard to data, I think there's often a tendency to say, "Oh, well, we've got to have an all singing, all dancing IT system, etc." I think we could do an awful lot just with a manual register with ruled lines and listing of people with particular conditions that we may need to make a special effort to reach out to. Or do we know how many people we have for whom Spanish is really their comfortable language, and that we really need to be reaching them in Spanish with Spanish materials? These things are not impossible. And so I think there are, and with regard to things like more complicated things like referral pathways for complex care, it's really a question of the colleagues sitting down and figuring it out, and working out which technical guidelines are we going to use, where are we going to send patients. Let's have the protocol all worked out, so that in an emergency we don't have to scrabble around trying to plan everything at the last minute. And it also allows, we have some excellent non-governmental organisations who do a tremendous amount in terms of supporting patients with particular conditions. We have I know there's the Nevis Renal Society. There's a paediatric association that rendered Paediatric Assistance League, which has really done a tremendous job in facilitating referral for often quite complex care when that's needed. So we're not starting from a blank sheet of paper. I think it's a question of how can some of these things be just focused a little bit more, and probably focused onto core agendas. And we have to also say there are certain things which we can't do. And we just have to say to persons in the Federation, well, we can't do that, and you have to be aware of that and make other arrangements.
Well, I asked the question because you specifically mentioned that to achieve access and quality for complex care solutions, that for referral to complex care must be accessible and affordable. And I think that is really important. Affordable, accessible, and preferably regional, since, as you pointed out, for urgent care issues, you have to get to it as soon as possible, like stroke and, cancer and so on. As soon as possible, you want to get the right kind of diagnosis. So if its possibility is within the region, Martinique, Barbados, Trinidad, then that can be very helpful, but it must be affordable, shouldn't it?
Yeah,
if we leave out the question of the sustainability, financial question of sustainability, that's important. I totally agree, but it must be affordable. Patients cannot go if they figure out how to pay.
There's a comment from Dr. Glenville Liebert about panic expenditure, and I think that's an extremely important one, that so many people, there's a sudden panic with either a very urgent condition or a very serious condition that requires complex care. And people can burn up huge amounts of money in a very short time. And I think that's, it's a very difficult one, but we need a plan to deal with that. I can almost imagine a kind of a job for somebody to be the health emergency referral coordinator that people can access. And because I know a lot of patients or relatives have to do this on their own. With the support of some of the voluntary organizations that there are, when there is a voluntary organization involved, I'm sure that really takes the burden off. But for many families, it's, they're on their own. And that's something that I think is largely a matter of organization. Yeah.
Well, we have a question from, you already addressed one part of this about the speak from Dr. Liebert. Speak to panic spending in health crises, where the crisis takes over and the money runs out instantly almost. Another part of this is age-related health problems are by and large predictable. How do we use those historical epidemiological data to more efficiently plan and manage scarce resources, both human and material.
That's an excellent point, and yeah, again, it reflects the fact that practitioners who've been practicing in this setting for many years have got their own archives and their own records of what's been going on, and the surprises are probably few. I mean, with the obviously the exception of weird things like COVID, but diabetes, heart disease, etc., and aging, and of course we do have an aging demographic in both from the in terms of we don't have a massive birth rate, I believe, in the Federation, but we certainly do have a lot of retired persons or people returning to the Federation in their retirement who are kind of bringing their health problems with them, which is both a challenge and an opportunity to try and systematize things a little bit more.
And really important because, as you mentioned, more and more of the people returning are retirees already. And even though people have, and some have excellent healthcare in countries that they're coming from, when you need instant care, when you need care immediately, it can become quite worrisome, if it always means having to fly out somewhere. Another question here, Dr. Stones, that's important, from Claire Louisi. Do small island states have large enough employed populations which can contribute to effective universal healthcare coverage for all?
Well,
as you were giving your lecture, this was occurring to me over and over again.
Yeah, I mean, I gave my disclaimer that I'm not an actuarial scientist, but I don't think you need to be an actuary to say no. It would be very surprising, and I wonder. I'd be very interested to know what the perspective would be from the business community. They might see this as yet another undesirable levy on their commercial activities, or employed persons. I think there are dependency ratios and statistics like that, which the actuarial people will no doubt be working on. But it does strike me as being a fundamental problem, and especially given the point that I made that the sickest people are not young and employed, in general. So I think that inevitably has to be some other resourcing mechanism, whether that's through direct taxation. I guess my personal favorite would be to have a sugar tax, but I'll probably be shouted down for that. Incidentally, it also speaks a little bit to the issue of one of the ways that insurance schemes try to contain their costs naturally is through the use of exclusions. And I think that is potentially a really hazardous route to go down because, I mean, for example, I think if I remember rightly, looking at the BVI insurance scheme, one of their exclusions is obesity, treatments for obesity. So I think Dr. Glenville-Liebert would probably agree one of the big health problems in the Federation and probably regionally is obesity as a predisposing factor for so many conditions, especially diabetes, cardiovascular disease. So now you're telling us that we can't have resources to manage obesity. I mean, that doesn't make any sense. So I think one would really want to, and again, I think this is why medical input is quite important, to really look at what's the fine detail of what might be proposed to say, well, hang on a minute, is this really the right way to go?
And look at what national health insurance plans are proposing, what's being proposed. Because fundamentally, insurance is always about the bottom line. It's saving money for the insurance company or the government, if the government is going to be the manager of the NHI. And so,
and Dr. Carty, I don't actually think that's a bad thing. And I mean, I think if you remember in that health systems framework, in the bottom right-hand corner, there was efficiency. And I think, I mean, this is our money, that we don't want the health system spending money on things which are not effective or wasting money, in through models of care which are not very efficient. So I think we have to have a kind of, and again, it speaks again to the governance issue that, we have to have a model where the governance model matches the both the medical outcomes or health outcomes, but also this aspect of efficiency and fundamental. I guess that comes on to sustainability. If it's not efficient, sooner or later it's going to collapse.
It can't be sustainable, that's right. In the chart that you put up at the end, the WHO Health System Framework, that was really insightful. Service delivery, health workforce, information, medical, productive, like production of vaccines and so on. Financing, leadership, and governance. And then on the other side, improved health, responsiveness, multi-risk international, and improved efficiency. These are really crucial. And in the center, we're looking at what drives them now: access to coverage and quality and safety. So what kind of quality care do we want? What kind of quality care do we expect? What kind of quality care would a government proposing a national health insurance scheme be focusing on to match its expenditure from its and what it's going to do to its GDP in terms of health? Those are really, really, really crucial questions. And I was hoping people would call in or write in with, some who may have more knowledge than we do. Like I studied the green paper as well that you mentioned, and the commission people who put this together, and what were those discussions? Because if you just read the green paper, you have a multitude of questions that it doesn't answer.
Well, it was intended to generate the discussion.
Yeah.
I would just touch on, with regard to quality, I think people sometimes assume that you can, I was emphasizing that for complex care, and especially complex surgery or interventional things, you need that volume to get quality and good outcomes. But that's not to say that you can't have quality even at a very local, at a health center, primary care level. And it's a question of defining your scope, the scope of services, and then ensuring that what you actually do matches what you say you do. That's a typical kind of quality model, where you're clear about what your objectives are and what you can do, what you can't do, and then that you function in a way that meets those requirements in terms of access, responsiveness, patient-centeredness or client-centeredness. So that's something that any health practitioner or any setup could aspire to. And again, we need to have those building blocks coming in, because otherwise I think there's a risk to say, oh, well, we can't really do anything until we get, new hospital, or we've got to have a new something or other, or, have everything funded to a massive extent. That's not true. We can do a lot in relation to quality with the infrastructure that we have. And then we're really talking about contributing in our own way to that middle section of the health system framework, and making sure that those building blocks are the most effective that they can be.
And I think the point that you mentioned at the end about, the naturopathic methods, for example, there's a wealth of indigenous knowledge in global South countries, because they have had to do without, and because of the financial limitations and the history of the indigenous knowledges that people have about healthcare, indigenous healthcare, herbal medicines and so on. So if we are developing a model that works side by side with allopathic medicine, that could be a huge advantage as well,
Yeah, I'm to some extent a skeptic of certain. For example, I don't believe in homeopathy, but there are many complementary therapies which do actually have a good evidence base. I think chiropractic, when it comes to musculoskeletal conditions, I think the research evidence in favour of that is very good. But there's also this dimension.
Acupuncture.
Yeah, absolutely. But I think we can immediately see the link with experience of care and that sort of responsive aspect. Imagine, let's take this topic of obesity. Imagine if we were planning a program for obesity reduction. Well, it would have a public health. Well, it would have a policy, a tax policy dimension. So we might well be reducing, we might well be increasing the tax or duty on sugary drinks and encouraging people not to put sugar in processed foods made locally, etc. But then we might have, I can quite imagine, you can see immediately how a wellness centre would look at somebody's lifestyle and their dietary habits. And we've got the ITAL cuisine very active in the Federation. So, how many persons have really maybe had the opportunity to participate in those parts of local knowledge for their health gains? And then, these are the things that we would really want to be doing, as well as any medical interventions that might be needed. So I think that kind of thing is if we can start to prevent diabetes or cardiovascular disease by engaging people's interest in good local food, less salt, less sugar, etc. I mean, this is not alien to any kind of traditional medical model. This is extremely complementary, and it's a tremendous resource that we have locally that we should pay due attention to and due regard to. So it's not, to me, it's not an either or. It should be seen as complementary. And again, it's not helpful to have, an insurance plan that says, oh no, you can't have cover for that. And that's where the care pathway thing comes in, that it can get over some of those random or potentially inappropriate exclusions. If something is included in a care package or a care pathway, then it's clear to everybody what it's for and what it's, what the extent of coverage would be.
You see, Isabel's question here, would Dr. Stone say that the COVID-19 pandemic has served to strengthen our health system and services in St. Kitts and Nevis to some extent?
That's a difficult one. I'm not sure that I would draw a direct connection. I know the Ministry of Health's made some very serious efforts for preparedness to deal with cases that they might need to deal with. And as we've started to see that requirement is actually happening. And of course, we've had the presence of the Cuban team to strengthen the medical and nursing capacity in the Federation. And there's also been quite a bit of equipment procurement. I'm not in a position really to comment on the wider aspects of functionality of the health system. I mean, as a practitioner, we are aware of certain gaps which are priorities for filling, which especially around things like imaging. And so I'm not sure that we could really draw a very clear pointer there. But I suspect that, well, one thing that has happened is a lot of people who probably were used to jumping off island when they needed any kind of healthcare, that jumping can't happen. And it's focused a lot of people's minds on services and what is available and what would happen if I needed X, Y, and Z. And certainly in practice, I get a lot of inquiries from patients about, do you have this? Can you do that? Etc. From people who perhaps might have been inclined to jump on a plane previously when in need. So that is in a way a good thing, because it's making people think more seriously and perhaps giving some impetus to building up the local capacity and local infrastructure, which I think has to be the way forward for the future in some of the ways that we've been discussing.
I do agree. I really think that focusing on the local and developing the local can take us quite far. And that's one thing that COVID
and local and regional. I mean, plugging into developing a good regional network as a regional public good. I'm learning my development jargon.
Yeah, as a development public good, it's important, because one thing COVID taught us is when you couldn't leave, you couldn't go anywhere, you couldn't just exit and fly out, then to Miami, for example, when the US wasn't taking anybody. I mean, it really forced Caribbean countries to look internally and look regionally. And I don't think we're going to have a post-COVID period. Learning learning to live with, these viruses is more like it. So we should try to develop that focus that we came to, or that awareness that we came to, that we could look regionally rather than externally always. And Dr. Libet has mentioned one last thing: prevention strategies through targeted education around identified problems will help improve performance metrics of quality care.
Absolutely spot on. I mean, that's the point. When it comes to identifying quality within a particular condition, management of a particular condition, that's exactly right. That if there is a consistent plan for care for a particular condition, and that's described, and there are indicators and metrics that develop to assess the performance in relation to that particular care pathway, then that's indeed is an extremely useful way to assess quality. It becomes possible to assess quality because it's, if you like, an auditor. I mean, and by this I mean a clinical auditor, not a financial auditor, can come along and say, okay, you say that your care pathway for breast cancer is this. Okay, show me the evidence of how it's functioning, and what are your indicators of success, and what do your patients say about it, most importantly. Yeah.
Well, I don't see any other questions, so this has taken us down to closing. And I want to say thank you for for me personally, a very exciting lecture. And I don't just say that because I have some medical knowledge from a previous life profession, but I think in terms of when I looked at the green paper, when I looked at, when I listened to your presentation and followed your slides, there's so much more that we can examine in this regard. So hopefully, UWI Open Campus will consider maybe even public presentations in St. Kitts and Nevis around these issues. Because once this goes on hold, once we get beyond the immediacy of dealing with the COVID crisis right now as it exists in the Federation, then I imagine we would get to things like public education on health issues and healthcare, especially because the green paper, the white paper that's in the cabinet at the moment, will be discussed more and more. So hopefully there's more space for this kind of work and this kind of discussion and this kind of education in terms of what the public needs. I think there's a dire need for this kind of education on all kinds of social levels. So through social media and other venues that this can be pursued. Personally, I want to thank the University of the West Indies Open Campus here in St. Kitts and Nevis, and specifically Gail Gray Phillip for putting this together and for hosting this very interesting discussion. And now we're going to turn to Isabel Byron from the center in Nevis, UWI Open Campus Center in Nevis, to give a vote of thanks. Hello, Isabel.
Hello, everyone. Good evening.
Thank you.
It is my pleasure tonight to express our appreciation to all those who made this public lecture the success that I think it has been. I wish above all to thank Dr. William Stones for consenting so willingly to collaborate with the UWI Open Campus in hosting this public lecture. He suggested the topic to me when I approached him, and I think it is of such relevance at national and regional level, especially at this very challenging and devastating time of the COVID-19 pandemic. And in light of the fact that we have had an ongoing discussion for some years about aspects of improving access to universal health care. Dr. Stone's presentation has done much to increase our understanding of the complexities of achieving universal health care, while underscoring its vital importance. And I think for us, he has really clarified vital issues and made it much clearer that it does go beyond simply the issue of financing. It goes beyond a very holistic and lifelong approach to healthcare, from birth to death, really. And I think all of us have become, I think it has helped, I think, the national discussion on the issue. And I hope many of the persons who tuned in, they may not have asked questions, but I do hope it will inform our policies going forward. And I think we're very fortunate to have Dr. Stones with us, and now we have links to him. We can use him in the future, I think, to provide a global perspective. I think he really positioned us globally, and not regionally and globally, St. Kitts and Nevis. I appreciate the sensitivity towards the issue of small island developing states and many very, very small states, as he pointed out, and our particular needs and challenges. And also, he ended, I think, nevertheless, despite all the challenges, he suggested some very pragmatic ways in which we could work with what we have and strengthen that without necessarily being overwhelmed by all the, the challenges that would, of course, arise when we're trying to meet all of the WHO criteria and targets. And he ended on a note of optimism for our future, I think, in building on our strengths. Dr. Carty, we very much appreciate having you as our moderator and discussant for this evening's presentation, for your willingness to collaborate with us, and for helping particularly to frame our discussion from within a local perspective, and looking at our local reality, and at the same time looking at our local strengths also, the fact that we have a lot of traditional knowledge and persons who are well trained and who can, with new ideas, go far in helping to develop our health system and services, and within this global perspective. To the UE Open Campus marketing team under the capable leadership of Dr. Cleveland Sam, I say a big thank you. You have provided excellent professional guidance and technical assistance, ensuring a smooth virtual experience, I think, and I hope, for all the persons who have tuned in via Facebook and YouTube. And thank you particularly to Patrick, our technician, who worked specifically with us on this event, and also to Ms. Cherise Glasgow, who has worked with the marketing team specifically in helping to promote this event. I wish to thank our head of the St. Kitts Nevis UE Open Campus office, Mrs. Gail Gray Phillip, for her leadership and guidance in this organizing this event, and to all of my colleagues at the UE Open Campus in St. Kitts and Nevis, who have contributed in one way or another. The team effort has been much appreciated. I think we've all learned a lot from this. And finally, I'd like to thank all the persons who tuned in for this presentation, and particularly those who made valuable comments and asked questions. This is an ongoing discussion. We're just at the beginning of it, I would think. I think this event tonight has really broadened the parameters that within which we need to look at what universal healthcare means and is. It definitely has enlightened me a great deal, and I think I have a lot of reading to do to become, again, more aware, further aware, and further an actor in this whole issue, because the way Dr. Stones presented it, I think it's the whole community. The whole community needs to be aware of what this means in order for it to happen. And so I think all of us can definitely contribute as citizens, and as whether we are providers or people benefiting from healthcare, and we all are that. Eventually, we all will be people who hope to benefit from improved health services in St. Kitts and Nevis and around the region generally. I thank again all the persons who tuned in. Your involvement assures the UWI Open Campus, St. Kitts and Nevis, of the relevance of our role in public education. And we deeply appreciate your support and participation. And as Linda said, where we do have public lectures from time to time, COVID, of course, has limited what we have been able to do, and the face-to-face engagement with the public that we normally do has, of course, been limited. But thankfully, we can still communicate with you on Zoom. So on behalf of all my colleagues at the UWI Open Campus, St. Kitts and Nevis, I again thank everyone and wish you all a pleasant evening, and that you hope that you all continue to stay safe. Thank you.
Good night, everybody.
Good night, everyone.